Okay, let's unpack this. Welcome to the deep dive, where we cut through the noise and get straight to the fascinating core of complex topics. Today, we're plunging into a medical mystery you might not expect to find quite so compelling: bovine atrial fibrillation.
That's right. And our mission in this deep dive is really to guide you through the most important insights from our sources. We want to help you understand this frequently encountered cardiac arrhythmia in cattle. We're going to explore its surprising causes, the intricate ways it's diagnosed, and the specific strategies veterinarians use for treatment. You'll find the condition has a surprising depth and often hidden impacts, not just for the animals themselves, but really for the wider agricultural system too.
Exactly. Get ready for some truly surprising aha moments, I think. This deep dive is crafted to be your direct path to being well-informed on a topic that kind of uniquely bridges animal health, agricultural economics, and some really fascinating physiology. So you might think you know atrial fibrillation from, well, human medicine, right? But did you know it's actually the most common cardiac arrhythmia found in cattle? It's surprisingly prevalent.
It truly is. To understand atrial fibrillation, or AF, maybe imagine your car's engine suddenly just running rough, like it's firing wrong. That's sort of what AF does to a cow's heart. Instead of the atria contracting in a coordinated, powerful way to pump blood efficiently, they just kind of quiver, they vibrate inefficiently. This disorganized movement leads to ineffective atrial contractions, which then impairs how the ventricles fill up with blood, and ultimately it slashes the overall cardiac efficiency. Critically, this drastically reduces cardiac output, especially when an animal is under high demand.
Like during milking.
Exactly, like during milking or other stresses.
Wow, that's a powerful analogy. So, given how serious AF can be in humans, what's the prognosis typically like for a cow? Is it always a critical situation, or, are there different degrees of severity we need to consider?
Yeah, that's a crucial distinction because just like in humans, it's definitely not a one-size-fits-all kind of prognosis. We primarily categorize bovine AF into two main forms. First, there's primary, which is also known as idiopathic or lone atrial fibrillation.
Idiopathic meaning no known cause.
Pretty much. It's diagnosed when vets can't find any discernible underlying cardiac or systemic diseases. Yeah. Interestingly, studies show it occurs in about 2.5% of apparently healthy Holstein dairy cows.
2.5%. That sounds quite high for healthy cows.
It is surprisingly high, yeah.
Yeah.
Then we have secondary atrial fibrillation. And as the name implies, this form is directly linked to an identifiable underlying condition.
Yeah.
Distinguishing between these two isn't just academic speak, it's absolutely critical. It forms the basis for guiding clinical management and predicting the long-term outlook for the animal.
Okay, so let's get right to it. Why should you, our listener, care about a cow's heart rhythm? What does this actually mean for someone outside, say, veterinary medicine?
Well, because the clinical presentation of AF in cattle has this surprisingly broad spectrum. It can range from very subtle, really non-specific signs, all the way to overt manifestations of cardiac dysfunction. So on one hand, you might see clear signs like a reduction in exercise tolerance, maybe they just don't move around as much, or a noticeable decrease in milk production.
Which is obviously a big deal for farmers.
Huge. In more severe cases, animals can exhibit clear signs of congestive heart failure, like visible swelling in the limbs, that kind of thing. But here's the kicker, and this is a key insight from the sources. Some cases, particularly that primary AF, may present with no overt clinical signs at all.
Wow, so completely hidden.
Exactly. This points to a significant potential for what we call subclinical disease, meaning it's lurking beneath the surface, especially within high-producing herds. And when AF reduces milk production in these undiagnosed cases, it imposes a significant unseen economic burden. It really underscores why thorough cardiac auscultation, simply listening carefully to the heart, is so important, even in animals that seem perfectly healthy.
That's truly fascinating to think about, that hidden aspect. And when we talk about what triggers this chaotic rhythm in a cow's heart, well, the causes are surprisingly diverse and often unexpected. Where do we even begin?
Okay, yeah, it gets interesting here. We should probably start with the most common associations. AF in cattle is most commonly tied to gastrointestinal diseases.
The gut.
Yes, the gut. Particularly conditions like abomasal displacement. That's when one of the cow's stomach compartments, the abomasum, literally shifts out of place, or other dysfunctions of their four stomachs. Now, while abdominal pain is often present, researchers hypothesize that other factors are deeply involved. Things like disturbances in vagal nerve tone, systemic inflammatory responses, or metabolic derangements that originate from that compromised digestive tract. What this implies, really, is that a thorough gastrointestinal examination should always be a mandatory part of the diagnostic workup for any bovine patient presenting with AF, even if the main complaint doesn't seem to be GI-related at first glance.
I would never have connected a cow's gut health directly to its heart rhythm like that. But it's not just the gut triggering this, right? What about other systemic issues that can throw the heart out of whack?
No, definitely not just the gut. Metabolic diseases and electrolyte imbalances are also frequently implicated. Specifically, hypokalemia, that's low potassium, and metabolic alkalosis are common culprits. They directly impair the heart's electrical stability and conduction. But here's where it gets really counterintuitive and quite surprising. Marked hyperkalemia, which is high potassium, can also induce functional atrial fibrillation.
Wait, hold on. Both low potassium and high potassium can cause this exact same heart problem? That sounds incredibly tricky to manage.
It is. It highlights an extremely narrow therapeutic window for potassium. Deviations in either direction are arrhythmogenic, meaning they can cause arrhythmias. The key insight here is that precise quantitative electrolyte monitoring and then targeted, very carefully titrated correction are paramount in managing bovine AF, because inappropriate or, say, overly rapid correction can actually be detrimental. It could potentially exacerbate the arrhythmia or even induce new life-threatening rhythm disturbances.
Wow. Okay, so electrolytes are critical. What else?
Well, beyond that, AF can also be associated with pre-existing structural cardiac diseases, things like valvular endocarditis, or traumatic pericarditis, that's inflammation around the heart, usually because a sharp object perforated something. Even myocardial damage from nutritional deficiencies like vitamin E and selenium deficiency, commonly known as white muscle disease, that can cause arrhythmias, particularly in calves.
Okay, and what about those idiopathic cases you mentioned earlier where there's no obvious cause? Is it truly just a mystery, or is there maybe something else going on that we're just missing?
That's a really fascinating question. And despite that idiopathic classification, histopathological studies looking at the tissue under a microscope have actually shown myocardial fibrosis, which is like scarring, particularly within the right atrium, in these dairy cows. This suggests there might be a subtle underlying structural pathology that's just not readily detectable by our standard clinical exams or imaging methods.
Yeah, some maybe not truly alone after all.
Exactly. It kind of challenges that notion and implies that idiopathic might simply reflect the limitations of our current routine diagnostic tools. And finally, there's a surprising link to iatrogenic risks. That means problems caused by medical treatment itself.
Oh, like what?
Well, the administration of dexamethasone, a corticosteroid that's commonly used in dairy cows for various conditions like ketosis, has been directly associated with the development of hypokalemia.
The low potassium again.
Right, the low potassium, and then subsequent atrial fibrillation. This highlights a significant iatrogenic risk. It means clinicians have to be acutely aware of this potential side effect and practice proactive electrolyte monitoring when using drugs like dexamethasone.
So it really underscores that it's rarely just a heart problem, is it? It's often a whole body systemic issue with all these surprising connections. And that complexity must make diagnosis incredibly challenging. If the signs can be so subtle, even hidden, how do vets actually catch this quiver? What kind of detective work is involved?
Yeah, the clinical presentation variability, from asymptomatic cases all the way to those with severe heart failure, it poses a significant diagnostic challenge. Relying solely on overt clinical signs will inevitably lead to misdiagnoses, especially in those earlier subclinical cases we talked about. This implies that maintaining a high index of suspicion and performing a meticulous physical examination are absolutely crucial for early detection. The absolute critical first step, though, and the most characteristic finding when listening to the heart auscultation, is an irregular heart rhythm.
Ah, the famous shoes in a dryer sound. That vivid description from the sources really sticks with you, doesn't it?
It does, and it's remarkably accurate for describing that chaotic rhythm. You might also find associated pulse deficits, where the pulse rate doesn't match the heart rate. Despite all the advanced tools we now have, accurately identifying this specific rhythm, just by listening, remains the most practical and immediate clinical clue for AF in cattle. It really serves as the first and most critical screening tool, especially in field settings.
Okay, so listening is key. What else do they look for during the physical exam?
Well, other physical exam findings can be important too. Inspection of the jugular veins in the neck might reveal abnormal distension or pulsation, although you do need to differentiate true pulsations from transmitted ones. And the presence of peripheral edema, that's swelling in the limbs, or ascites, which is fluid accumulation in the abdomen, Those are significant findings. They usually indicate right-sided congestive heart failure, which unfortunately suggests more advanced cardiac disease and generally a guarded prognosis.
So auscultation gives a strong suspicion, but what's the definitive proof? How do I absolutely confirm it's AF?
Right, that's where electrocardiography or ECG comes in. It's the definitive diagnostic tool. Think of an ECG like a musical score for the heart's electrical activity.
Hmm.
Normally, you see these distinct P waves. That's like the prelude signaling the atria are about to contract in an organized way. With AF, those P waves just vanish. They're replaced by this chaotic scribble, like someone just dragged a pen across the baseline. These are the F waves or fibrillatory waves. Very rapid, irregular undulations. And instead of a steady, predictable beat, the rhythm is completely erratic. That's your irregular RR intervals. The time between each main heartbeat is all over the place.
Gotcha. And the main beat itself?
Typically, the QRS morphology, which represents the main ventricular contraction, remains normal or close to normal. Now, while standard bulky ECG machines can be impractical out in the field, portable ECG devices are becoming increasingly available, and they significantly improve diagnostic accuracy and accessibility right there on the farm.
Okay, ECG is definitive. What about imaging, like ultrasound?
Yeah, echocardiography, or cardiac ultrasound, is also a very valuable tool. It's used to assess the heart for structural diseases, things like valvular lesions, changes in the heart muscle itself, or atrial enlargement. Its crucial role is really to help differentiate that functional AF, maybe linked to electrolytes, from AF that's secondary to irreversible structural heart disease. And that distinction is absolutely vital for giving an accurate prognosis and planning the right treatment approach.
Makes sense. And what about blood tests? Do those help paint the picture of what's going on systemically?
Absolutely. Laboratory diagnostics are indispensable, really. Electrolyte analysis measuring things like potassium, calcium, sodium, chloride, maybe total CO2 for acid-base status is essential for optimizing fluid therapy and correcting those imbalances we discussed.
Right, the hypo and hyperkalemia.
Exactly. Hyperkalemia, and metabolic alkalosis are frequently associated with AF. We also look at specific cardiac biomarkers. Cardiac troponins can indicate if there's been myocardial injury, damage to the heart muscle. And natriuretic peptides reflect atrial pressure and mechanical stretching, and they can even help predict if AF might recur after treatment. Yeah, and blood gas analysis is also crucial for identifying acid-base imbalances, like metabolic alkalosis, which often goes hand in hand with these issues. The combined use of electrolyte analysis and these cardiac biomarkers provides a really powerful, multidimensional view. It helps with both rapid stabilization of the animal and figuring out the informed long-term prognosis. And finally, it's worth mentioning, when a vet detects any irregular heart rhythm, it's crucial to consider other possibilities too. Things like sinus arrhythmia, premature beats, maybe certain types of heart block, and numerous systemic disorders that can sometimes mimic AF clinically. This really emphasizes the need for that definitive ECG confirmation. You have to be sure you're treating the correct underlying rhythm disturbance to avoid misdiagnosis and potentially harmful inappropriate treatments.
Okay, so that's a lot of detective work. Once a vet does catch this quiver, once they're sure it's AF, what's the game plan? Is there a magic bullet for treatment or like a standard protocol they follow?
Yeah, there's no single magic bullet, unfortunately, but there is a clear, prioritized strategy. For secondary AF, remember, that's the type linked to an underlying cause. The primary therapeutic focus must be on identifying and correcting that underlying systemic disease. This approach is crucial because, quite often, the AF actually resolves spontaneously, typically within about 5 days, once the primary issue, like a gastrointestinal problem or a metabolic imbalance, is successfully managed.
So fixing the gut problem might fix the heart problem automatically.
In many cases, yes. It means that for most instances of secondary AF, the immediate strategy should be directed at the systemic illness rather than jumping straight to aggressive, direct antiarrhythmic drugs for the heart. This is often more cost-effective and generally carries fewer risks for the animal. So this involves, prompt and effective correction of conditions like abomasal displacement, aggressive recognition and treatment of electrolyte issues like hypokalemia, and also administration of ancillary treatments for any concurrent diseases the cow might have, like botrytis or mastitis or ketosis.
Okay, that makes sense for secondary AF. But what if fixing the underlying cause isn't enough? Or what if it's primary AF with no obvious trigger? Are there specific drugs for the heart itself, like the ones used commonly in humans?
Yes, there are, but, and this is but they come with significant caveats in cattle. Quinidine sulfate is considered the primary pharmacological agent for converting atrial fibrillation back to a normal sinus rhythm in both horses and cattle. It's typically administered orally, often given via a nasogastric tube. But here's the critical point. Quinidine is a potent antiarrhythmic drug that carries a significant risk of adverse effects.
Like what kind of effects?
Well, it can potentially worsen the arrhythmia. We call that proarrhythmic effects. It can also cause severe cardiotoxicity, leading to dangerous ventricular arrhythmias, changes on the ECG like increased QRS duration, potentially cardiac arrest, or it could even exacerbate underlying heart failure. And on top of those heart risks, it also commonly causes gastrointestinal side effects like diarrhea, nausea, and anorexia.
Wow, okay. So it sounds like a very powerful tool, but one that comes with really serious risks. Not something you'd use lightly.
Absolutely not. The extensive list of severe potential side effects necessitates a really rigorous risk-benefit assessment before even considering administration. It is definitely not a routine first-line treatment for all AF cases. It's generally reserved for situations where spontaneous conversion seems unlikely or maybe has already failed, and the animal's economic or sentimental value justifies the inherent risks and the intensive monitoring, which includes repeated ECGs and measuring serum quinidine concentrations that's absolutely required when using it.
Are there other drug options besides quinidine?
Digoxin can sometimes be used as an adjunctive therapy. Perhaps a conversion to sinus rhythm hasn't occurred with quinidine within, say, 24 to 48 hours. But again, careful monitoring of digoxin levels is needed, especially if it's combined with quinidine, as quinidine can actually increase digoxin concentrations in the blood. And it's important to note this relatively narrow range of established antiarrhythmic drugs for bovine AF, especially compared to human or even small animal medicine. It really highlights a pressing need for further research into newer, potentially safer agents for use in cattle. There's a significant gap there.
Yeah, that's clear. Given those limitations and risks with the specific heart drugs, it really sounds like fluid and electrolyte management isn't just supportive care, is it? It seems absolutely central to effective treatment.
That's precisely the insight. You've nailed it. In bovine AF, fluid and electrolyte therapy is elevated beyond just support. It becomes a direct, critical therapeutic intervention. Fluid therapy protocols need to be individually tailored, often using crystalloid solutions like 0.9% saline or lactated ringers for general volume replacement and correcting dehydration. Sometimes hypertonic saline might be used for rapid volume expansion if the dehydration is severe. And then there's the specific electrolyte correction. For hypokalemia, low potassium, supplementation with potassium chloride or KCl is crucial. It can be given orally or intravenously, but the intravenous rate has to be carefully controlled, not exceeding 0.5 milliequivalents per kilogram per hour to avoid causing problems.
And for high potassium?
Hyperkalemia. For hyperkalemia, the treatment is different. It might involve intravenous administration of plain saline, 0.9% ACl, sodium bicarbonate, glucose, sometimes insulin, and occasionally calcium, depending on the severity and the specific situation. Careful attention also has to be paid to sodium concentrations, avoiding overly rapid changes, usually not more than 0.5 milliequivalents per liter per hour, to prevent potential complications like cerebral edema. And for acid-based problems, sodium bicarbonate or sometimes hypertonic saline might be used to correct acidemia, which often accompanies severe electrolyte disturbances. Also interestingly, administering calcium, like calcium borogluconate, can sometimes help restore normal abomasal motility in those GI disorders, which can indirectly aid AF resolution.
It's incredibly complex, isn't it?
It really is. The crucial takeaway here is that inappropriate or overly rapid corrections of these fluid and electrolyte imbalances can actually exacerbate the arrhythmia or induce new, potentially fatal complications. So a nuanced understanding of fluid and electrolyte balance is truly as critical, if not sometimes more critical, than the antiarrhythmic pharmacology itself for successful AF management in cattle.
Okay, given all these complexities, the different causes, the treatment challenges, what's the ultimate outlook for a cow with AF? Is it usually good, or does it often lead to severe consequences down the line?
Yeah, connecting this to the bigger picture. The prognosis is highly dependent on its underlying etiology, on the cause. This fundamental difference really dictates the entire management approach and the likely outcome. For AF that is secondary to those treatable underlying gastrointestinal or metabolic diseases, the prognosis is generally favorable. As we said, the arrhythmia often resolves spontaneously once that primary condition is successfully corrected.
Okay, that's good news for those cases. What about the primary idiopathic kind?
For primary or idiopathic AF, the prognosis can be more variable. There are some documented cases where primary persistent AF didn't seem to compromise reproductive performance, which is obviously important. But it's important to remember that underlying myocardial fibrosis, that scarring, may still be present even in these apparently idiopathic cases, and that could potentially influence long-term cardiac health, even if the rhythm disturbance itself isn't causing obvious problems initially.
And what about the third scenario, when there's an irreversible structural issue with the heart itself causing the AF?
Right. If AF is associated with irreversible underlying structural heart disease, think severe valvular endocarditis or advanced myocardial disease, then the prognosis is generally guarded to poor. These cases are often linked to things like stunted growth, poor productive performance, and unfortunately, an increased risk of sudden death. And while surgical correction for certain congenital heart defects is technically possible, it's often just not economically viable in production cattle. This makes these cases particularly challenging for producers and veterinarians. So that critical differentiation we talked about, performing a thorough diagnostic workup to figure out which category a case falls into, is absolutely paramount for having realistic conversations with clients and making ethical decisions, especially in production animal medicine, where economics plays such a large role.
Okay, so here's something that really jumped out from the sources, a truly maybe shocking insight. Even if a cow's heart rhythm is perfectly restored, the financial damage from that initial episode of AF, particularly if linked to something like a displaced abomasum, can linger for potentially a full lactation. What does this actually mean for the farmer?
Yeah, you're hitting on a crucial economic reality there. While achieving clinical resolution, getting the heart back to normal rhythm, getting the cow healthy is definitely a success from a veterinary standpoint, the potential for long-term productivity losses, even after successful treatment, is significant. The example you mentioned is key. Dairy cattle successfully treated for left-displaced abomasum, which is a common underlying cause of secondary AF, may produce approximately 557 kilograms less milk during the subsequent lactation compared to their unaffected herd mates.
Wow, over 500 kilos less milk.
Exactly. It's like a hidden tax on the farmer from that one illness episode. It really highlights that successful treatment, in a clinical sense, doesn't always equate to complete economic recovery for the producer. So veterinarians really need to engage in nuanced discussions with owners about these expected long-term performance impacts and the overall economic viability of treatment in the first place.
That's a huge consideration beyond just the immediate vet bill. And thinking long term, what about management? Is the goal always to convert the rhythm back to normal sinus rhythm, or can some cases be managed differently if conversion isn't possible or maybe not even necessary?
That's another great point. It's not always about conversion. For cases where AF doesn't convert despite treatment, or perhaps for cases of primary persistent AF that aren't causing significant clinical signs, maybe the heart rate is reasonably controlled, the cow seems otherwise fine, then a watch and wait approach might be appropriate. This is especially true if the heart rate remains within acceptable limits and the animal shows no other adverse clinical signs like heart failure or poor production. Of course, regular monitoring of the cardiac rhythm, clinical signs, and crucially productivity is essential in these cases to detect any progression or developing complications over time.
What an incredible deep dive this has been. Really fascinating. We've journeyed from the fundamental definition of bovine AF and its different types to its diverse and often really surprising causes, especially those common gastrointestinal links and the very tricky electrolyte imbalances. We explored the meticulous detective work of diagnosis, from that memorable shoes in a dryer sound on auscultation right through to the definitive ECG, and then the nuanced, sometimes risky treatment strategies, highlighting that absolutely critical role of careful fluid and electrolyte management.
It truly has been quite a journey through the sources, and I think the core message here is that successful management of bovine atrial fibrillation really relies on a comprehensive, multimodal diagnostic approach. You need to use all the tools. It also requires targeted therapy tailored specifically to the underlying cause and a clear understanding of both the clinical and the economic implications for the affected animal and the entire production system. And as we discussed, that limited range of established antiarrhythmic drugs specifically for cattle really does highlight a pressing need for further research in this field.
Absolutely. So, as we wrap up, here's a final provocative thought for you, the listener. What stands out to you from all this? Thinking specifically about that hidden economic burden, the lost milk production from seemingly healthy cows with subclinical AF. What does this imply about the true cost, or maybe the value, of wellness checks in agriculture? And how much more could potentially be gained from proactive diagnostics that we might not even be routinely considering yet?